only mode.
Welcome. Thanks for joining us today for the second webinar in our series, We Believe Experiences Matter. I'm Pamela Stoffergan-Gay, Senior Marketing Manager at Centric, and I'll be moderating today's presentation. Today, Robert Schumacher will discuss usability and electronic health records. Managing Director and co-owner of Centric, Bob has more than 25 years of professional experience. Editor of the Handbook of Global User Research, author of several patents, and dozens of professional and academic papers, he's recently become influential in how usability is applied to health information technologies. Bob has authored several papers on usability criteria in the EHR selection process and co-authored a document that focuses on usability testing and evaluation of EHR systems. A member of the National Research Council's Committee on the Role of Human Factors in Home Healthcare and co-director of the Program on Usability Enhancement in Health IT at the Northwestern University Feinberg School of Medicine, Bob has been actively involved in developing usability criteria for these systems and is often called on to lend his expertise on the usability of this technology. Before I hand this over to Bob, if you have any questions during the presentation, use the GoToWebinar dashboard to send in your questions, and I'll compile them for the Q&A at the end of the presentation. I'll also be monitoring the chat window, so if there are technical issues, we will try to address those as well. Take it away, Bob.
Thank you, Pam. Greetings, everyone, and happy Valentine's Day today.
I wanted to start out with oftentimes when we take a look at a topic like usability, we define it in terms of what it is not. So let's do that. Let's take a look at what usability is not. Usability is not about an aesthetic, usually, and we'll get to a little bit more of this in a minute. It's not typically about aesthetics. It's also not related to functionality per se. Does the device or application do something? It's not in the realm of user acceptance testing, for example. It's also not about attitude and opinion, the kind of things that we would find in market research or in a focus group. So if usability is not those things, one of the reasons is because what people say is often not what they do, or in other terms, everybody lies. But there are a couple of caveats, and I just hinted to those. When we talk about usability, we look at usability and how it is a part of user experience. Usability is only a part of the overall user experience, which is those other things, which is about satisfaction, it is about aesthetic, it is about how you feel and work with a product or an application. The other part, the other caveat comes down to utility or functionality. We can find usability and utility almost on independent axes. So if, in fact, you look at an iPhone, it is both high on the usability scale, but it's also pretty high on the utility or usefulness scale. So it actually turns out to be pretty good because it's both useful and usable. We can look at other products like the Tamagotchi. For those of you who are old enough to remember such a little electronic pet device, it is not a very usable device because it's only got 3 buttons and lots of different functions, but it's also not a very useful device unless you're really looking for something to entertain yourself in a very short time frame. Compare that to an electronic translator, for example, which is very usable because one can type a word in there and translate it to another language, and it may be very useful, and it may be very usable,
but it's not
very useful in trying to carry out a conversation.
Contrast that with a very high-end remote control, which may be very useful, but may be very low on the usability scale. What does this all lead to? It leads to the fact that usefulness or utility does not necessarily mean usability. Likewise,
something that is usable doesn't necessarily mean that it's useful. Now that we've sort of set those things up, let's talk about what usability is and how it is typically defined. if we look at the common definition of usability, which is something that that is, sorry about that, we got to get ourselves back. Okay. If we look at the common definition of usability that comes from ISO, the usability is defined as the extent to which a product can be used by specified users to achieve specified goals with effectiveness, efficiency, and satisfaction in a specified context of use. There are a number of things in this that we really need to unpack to help us understand what we mean by usability. There's really, I think, three different components here. The first is specified users, specified goals, and those are typically defined as tasks that people have to achieve. And then the context of use, the specified context of use, or the environment in which something is being used. So when we look at usability, we're always looking at users, tasks, and environment. And then what we want to measure are things like effectiveness, efficiency, and satisfaction in those environments. There have also been several different addenda to this description, but for the most part, this is a very common definition and one that's used quite frequently. So if we talk about usability, then there's really two things that we do with you in the context of usability. We either measure things or we change things. We measure things or we change things. That's it. And we do the measurement and change by applying certain things. And what it is that we measure and change is human behavior. And usability is about measuring and changing behavior in one way or another. Behavior is the realm, of course, of psychology, and particularly cognitive psychology. Underneath that, a more applied area of human factors. And in a very loose kind of analogy, you can say that engineering is to physics as human factors is to psychology. And usability, of course, feeds very much into the whole human factors realm. Where am I going with this? Well, we'll talk a little bit about what this means in terms of measurement and change. If we look at some of what we can gather from psychology and from the background of human behavior, we can say that there are certain things that we know. So reaction time is a measure of performance. Errors are a measure of cognitive load. Eye tracking is one measure of attention. So within psychology, there's a rich history of constructing certain kinds of studies that help us understand and explain human performance. Likewise, however, we can take a look at some of the properties of behavior that inform design, that help us change human behavior. So if we understand memory, or if we understand certain motor capabilities, or if we understand how people find signals in a field, we can do a better job of doing design. That knowledge of human capabilities, if we put that into design, it can help us optimize the user performance. Okay?
Okay, is that better?
Try to go through the next slide, and we'll see if the audio is better. If you can give me feedback, if you're still having issues, that'd be great.
Great. Sorry about that, everybody. We're just starting to get on a roll here. So if we take a look at these as sort of the principles that help us measure, or the methods of measuring behavior, and the principles of behavior that can help us understand design, let's take a look at two specific examples of this. First, let's take a look at reaction time and performance that is a result of some of what we know about psycholinguistics. And bear with me, I am going to make this more relevant to EHRs and HIT. This does sort of feed into that. But what I want you to do is take a look at the examples that are on the screen. So look at these two the circle and the star. And I want you to answer yes or no as quickly as you possibly can when I bring up this next example. Okay, so that was probably pretty easy, right? It was a positive statement with an affirmative yes response. Okay, let's do this again. Ready? The circle is not above the star. That was a negative statement with a no response. It is a known property of language that positive statements evoke faster responses than negative statements. And yes responses are much faster than no responses. Why is this relevant? Well, let's take a look at this. Place all patient orders. Yes or no? Cancel all patient orders. Yes or no? These are both, in a way of speaking, positive statements with easily responded to outcomes. Now, take a look at another one. Do not cancel all patient orders. Yes or no? Affirmative response. Do not place all patient orders. Yes or no? Negative questions, negative response. In short, different phrasings are used when you want different responses or need different responses. There is a large variability in the processing times of these two kinds of statements. So very small changes in wording and very small patterns of response can have a significant impact on both performance time and on errors. So effectively, when we're looking at these, we would say a statement type that is true with an affirmative response are fast, easy, low cost to the user outcomes, and they're usually used for confirmations. False affirmative responses are used when you want the user to actually think about the response, and there's a high cost to error involved. A true negative response should almost never be used, and a false negative you would never use unless you're trying to deceive the user. We see this very frequently in opt-out kinds of responses on a lot of forums. So let's take a look at another example here, just when we want to take a look at signal detection. Signal detection, there's a great example. If you're a radiologist, one of the things that radiologists do, in fact, is they try to find signals in a bunch of noise. So they may be trying to find a broken bone or a cancer or another anomaly. But we're going to use something a bit more pedestrian to help understand signal detection here. We're going to need our friend Waldo. And this should be a fairly interesting example, because we'll get to an HIT example in just a minute. So what I want to do is I want you to find Waldo when I bring this up. Okay. Waldo's right there. Very simple. There's a high signal to low noise ratio. But if I give you that, it's a much lower signal to noise ratio. There's a lot of noise and the signal is not very strong. In fact, Waldo, if that's even Waldo, is right there in the frame. So what's the point here? Well, the point is, let's look at a screen that might come up in a typical HIT or EHR scenario. So someone might want to find out when the patient's highest, when was the highest platelet count for this patient. So discovering this information on this screen is much more difficult. Is difficult largely because there is an overuse of coding of information. There's an incorrect coding of information. The answer is right here on the platelet count. It's difficult to find because there's so much noise on the screen and the signal is not very strong. What do we? The bottom line to learn out of this is human performance depends on how well tools are designed. Change the interface and we can change performance. We can change the interface for the positive or change the interface for the negative. But how do we measure that change, and how do we understand the users, the tasks, and the environments in which they work? Well, we come back to this diagram where we're looking at usability methods and user experience methods, and we find out that usability methods are oftentimes are embedded underneath user experience research methods. Some of those methods involve users and some do not involve users. For instance, if you're going to be using a cognitive walkthrough It typically doesn't involve a user. If you want to do a heuristic evaluation, there are often not users involved, or doing a keystroke level model under the GOMS framework does not involve users. However, we're more familiar with the kinds of methods that involve users, such as validation testing or formative usability testing, eye tracking, etc. These are ways in which we can measure or help guide, measure performance or help guide design through certain kinds of activities. Card sorting, for example, is one way in which we can help understand the framework by which one would design the user interface. So the usability workbench, not to be too cute here, has several different tools in it. But the problem is often, or the trick is often, to know when to use each tool. And if we kind of turn this on its head and say, all right, there are a number of times in which it's very appropriate to use a focus group, and other times when it's very appropriate not to use a focus group. What are those? What are those dimensions? What are those times that one would use to choose one technique over another? And if we look at a number of dimensions, for instance, we can say, are we trying to describe the interface, or are we trying to improve it? Are we looking at it in the field, or are we looking at the interface in the lab? Is the interface deployed, or is it still in development? Do we want to get qualitative feedback about it, or is quantitative feedback the kind of information that we're really looking for? Are we trying to find absolute information about the performance of the user, or do we want to know relative performance of how someone performs on one interface or one design versus how a user would perform on another design? What are the properties of some of the users, and so on and so forth. So if we go back to that framework of understanding users, tasks, and environments, some of these dimensions, in fact, help us understand users, and some help us understand environments and tasks. By understanding what it is that we're trying to get at, are we trying to understand the properties of the users in relationship to the tasks and the environment, then we can do a better job of selecting the tools. So let's just take a look at how we would look at those tools relative to a few of these dimensions. First, let's take a look at two dimensions, whether we're trying to describe the interface or whether we're trying to improve it, whether we're looking at it in early development or whether we're looking at it in a fully deployed environment. And if we take those methods and lay it out against these dimensions, we can see that there are different times to use different methods. If we're trying, for example, to do to describe performance, not to improve it, but to describe it on a system that's almost ready to be deployed, validation testing is something that we would very much be interested in using. On the other hand, we would never use something like focus groups to do that, because focus groups really help us early in the development phase, and they're really geared toward understanding or improving an existing design. So let's take a look at two other dimensions. Are we trying to get at behavioral data, or are we trying to get at attitudinal data? Number one. And on the other dimension, are we looking for qualitative or quantitative kinds of information? Again, if we lay out the particular tools that are available to us, what we see is that there are certain properties and different kinds of different techniques will work better in different areas. So if we're trying to understand in a very quantitative way and really get a handle on behavior, then we're going to want to look at validation testing rather than something like formative testing or focus groups or surveys or participatory design. The reason why I contrast this a lot with focus groups is that from at least our experience, one of the key areas that most people in health information technologies often point to is that they may in fact impanel a group of doctors and have focus groups or have panels and discuss the performance or the functionality of the interface relative to that or with that panel. And the panel can give you certain attitudes and opinions, but it's really not geared toward understanding the behavior and the quantitative nature of the information that gets presented. So with that in mind, we're going to turn to really some of the other key parts of what we wanted to talk about today. So in the context of developing user interface guidelines and guidance for how one evaluates and measures the user interface, a number of people, myself included, have been involved heavily in the development of the National Institute of Standards Usability Protocol. It is still still has yet to be released. I understand it should be released soon. I want to thank, if there was anybody on the line who was a party to reviewing and helping us sort through some of our thinking here. We do believe that it became a much better document after we had all of the content and feedback from lots of folks. Our collaborators on this, Lana Lowry is the lead author, and then I don't have Matt Quinn on here, but Matt Quinn was heavily involved, as was some other folks as were other folks at NIST, and so I can't possibly thank everyone who was a party to that, but it was very much a group effort. So let's talk about this in particular. The objectives of the protocol were, first of all, to apply existing established human factors methods to understanding and measuring the usability of electronic health records. We wanted to focus particularly on the usability of EHRs relative to patient safety. So anything that would impact use errors that was related to the usability of the EHR. We wanted to provide detailed systematic steps for conducting validation studies as well as expert reviews. And then lastly, provide a framework for reporting on usability findings. I have to stress that that the document was not a policy document or a framework document for anything related to that. It was purely a document intended to provide guidance for the technical evaluation of electronic health records. And at this point, all I can tell you is that the document will be released soon, and we'll go into some of the details here. Unfortunately, we don't have a lot of time to go into detail, so once this gets released in the next few days, I hope, everyone will have a chance to take a look at a lot more of the details of it. Within the document itself, we really cover off three particular steps, three particular areas. The first is an application analysis, and I'm not going to talk very much about this other than just introduce it. And then, because what we're really trying to do is review the application relative to a variety of critical use risks, or take a risk-based approach and look at the interface and do a lot of the formative upfront work that's required to bring the application to a point of being very finished in its final presentation. Remember, this document is not geared toward formative testing or user-centered design. It is purely geared toward the very end of the development cycle. So next, we want to talk about an expert review or analysis of the electronic health record, identify any design issues, feed those back. This is more guidance and formative and qualitative evaluation, although there is a great deal of emphasis here on just doing due diligence on a variety of human factors defined criteria, as well as risk-based criteria that my colleague Emily Patterson added to the expert review. And then last, a usability test cycle that is based upon validation testing, and you'll notice that I'm using the term validation testing, not summative testing. We've actually changed our language here very specifically because we found that the terms formative testing and summative testing were very confusing, and so we kind of pulled back from industry-related terms and tried to use something that's a bit more understanding, more broadly understood. Okay, the document itself is organized as follows, where what we're wanting to do in the document is lay a foundation for EHR usability. So we talk about some of the research findings and review the upcoming steps. We spend a lot of time going through some of the application portions, and then the expert review in step 2, and in step 3 the validation test. What you'll see, what is a critical component of the document itself, are the appendices, where we lay out in pretty gritty detail the kinds of things that one ought to look at. Everything from a recruitment screener to a test guide to consent forms, ratings, and even receipt forms and acknowledgement forms. So if we look at application analysis, which is step 1, it really is a foundation for going through those three things that I talked about earlier that are part of the definition, which are who are the users, what are the environments, what are the tasks, and then doing a risk analysis, going through understanding, are there areas in here where where risk that is associated with the user interface is present. What mistakes could users make? One of the common things that I often see when looking at EHRs is looking at formulary lists that are truncated. And so if you see a drug list that's truncated, it's very hard sometimes to understand what the full prescription or what the e-prescribe might be based upon just looking at that list. And so there are things that can be done before we get further into that design and evaluation cycle that can be weeded out before we have a more formal review. Has the application then been designed to mitigate use error? In terms of an expert review, the second step, there is a protocol that's been established that, from a definitional standpoint, what we're trying to do is provide an evaluation of critical components of the interface, where by executing various use case scenarios. So we've got 3 use case scenarios in the document itself and 3 of the appendices. And so by using those scenarios and stepping through the EHR, one can make an evaluation. Generally there are 2 different types of folks involved in this analysis. The first is critical or clinical experts. The second is a group of, or 1 or 2 usability experts. And the 2 of them go through together to understand what those risks might be, and they conduct a structured evaluation of the user interface using a guideline that's been set out in one of the appendices. It's a very detailed guideline that's been adapted for use. So the process is to review the criteria in the process, select the team, conduct the review, so selecting the experts, selecting the methods by which the review will be done, produce the ratings and the findings. As you can see, I've got at least one example down there before, or down there below, where we're trying to look at a match between the system and the real world is the heading on it. But we're really trying to get at very specific things. So, for instance, 3.3, does selected colors correspond to common expectations about color codes? This might be something that the human factors or usability expert is going to pay attention to, but maybe the clinical expert may not have a lot of background in. Similarly, there are other parts of the expert review that have clinical components that the clinical expert will understand and that the human factors person or the usability person might not get, which is why we want to have both kinds of expertise, both clinical expertise and human factors expertise, to be able to do this. Once all the experts have completed the evaluations, a lead expert then consolidates all the findings into a single report, and we deliver those conclusions and recommendations to the team. So these tend to be very qualitative kinds of adjustments and qualitative fixes, but it also provides a really good read on the overall user interface, the performance of the user interface with respect to a couple of very critical users. Okay, so now let's get into step 3, which is the meat of what I'll be talking about from the balance of the time, and that is what is validation usability testing. Validation testing, I kind of laid out in a couple of those dimensional charts, is really quantitative, and it relates to the behavior of the users in the with respect to some of the scenarios that are laid out. It's done usually after several rounds of formative testing. Formative testing is done to inform design and development, and occurs very early in the product life cycle, often as diagnostic testing to see how well changes have been received by the users, how they affect performance, what kinds of things are working well and what are not working well. And it is aimed at identifying and addressing weaknesses in design. And more importantly, and particularly for validation testing, it's done to identify use errors that could be associated with the design. Validation testing formative testing is often iterative in nature. It is largely qualitative. This is to differentiate it from validation testing, because validation testing is really designed to go after a larger sample size and perhaps weed out more subtle issues and understand how performant the application is with respect to the goals, the users, and the tasks, and the environment. As I mentioned before, it's frequently referred to as summative testing, and it's ultimately aimed at evaluating and design and demonstrating that it is ready for use. So how does one set up a validation test? There are really about seven steps, and I'm not really trying to go through the details of each of these, so I am going to kind of skim over the top because there's a lot here, and we can talk about specific examples if and when we get there, or when we get to questions. So, all right, so how does one set up a validation test? There are a number of things. Create the test plan. We've got to get some participants, some users. We have to have the EHR ready to use. We have to have a moderator's guide, set up a test environment, and actually conduct the field work and conduct the test and report on those results. So if we're looking to create a test plan, there are a number of things that we want to have in the test plan. We need to understand who the users are, what tasks we want to select, and why we want to select those tasks. Ideally, what we're trying to do is understand those areas that present the greatest, at least within the EUP framework. We want to understand the areas that have the highest potential for patient safety risk related to usability. And so we want to pick at certain things that may be more difficult just to make sure that we've done our due diligence in ensuring that the application is safe and effective to use. As I mentioned, within the document, there are 3 scenarios that are laid out that are intended to be cases against which tasks can be written. We opted within the framework of the document not to be overly prescriptive about the specific tasks that are to be used, because there's such a broad range of EHRs on the market, and there's a broad set of use cases. So we provided the scenarios and really enable the particular users to select the proper tasks relative to those cases that might be most difficult within that EHR. The test plan also has to enumerate or elaborate on the testing environment. The criteria for success have to be laid out, specifically where is the testing going to take place, and then if there's any training that needs to occur with the users, that training plan needs to be put out there. Recruiting and scheduling participants is an interesting topic here, but I think the primary point whenever we try to recruit participants, the second bullet is the most important, because the participants should be representative of the users of the application. And there was a lot of conversation, a lot of discussion about representative users in the comments that we got back from the EUP when it went out for public comment. And it is a difficult topic, and I think our objective was to try to pick the best solution from a number of difficult ones. But typically we want to get people who are less familiar with the application so that we are not overwhelmed, I guess, or we're able to control better the kinds of knowledge that people have if we know that they don't have any knowledge of the application, which also means that we have to give them some level of training as they come in to perform the tasks. We recommend that a minimum of 15 users per distinct user group. If there are multiple user groups, then 15 users per user group is usually a number that will give us a stable enough data set as we begin to collect the information about performance. Setting up the EHR, well, most EHR applications are almost always customized and very often personalized, which makes it a difficult deal to set up. For testing, we'd like to have the application be in its most typical configuration, and they should be a recommended configuration, obviously, with respect to the hardware, software, and the network on which the EHR is going to be tested. We have to develop the moderator's guide, and to maintain consistency, it should be highly scripted so that every participant receives the same information at each session for each task. We want to prioritize and focus the tasks on functions that could potentially have an impact on patient safety. At least that's how we had set it up in the EUP. The moderator's guide also provides instructions for recording data elements such as time on task, screens visited, ratings, any regressions in behavior, any regressions to different screens, etc. If possible, at this point too, the moderator's guide should anticipate any errors and log a description and classification of those potential errors. Setting up the test environment itself, this is the facility in which the testing is going to be taking place. This is also a difficult topic to try to wrestle because one wants to have reduce the total number of factors that could negatively affect performance. So you could test either in a test lab or in a simulation lab. At this point, we believe that the best solution is to get people out of a busy clinical setting and bring them into a simulation lab. The testing facility also has to be accessible to ADA, and should be compliant with OSHA standards. Conducting the fieldwork or conducting the test itself, typically the user has to be provided with instructions to offer context for the test session. The administrator and the data logger will in fact administer the test and then collect data as the user is going through the various tasks. And I mentioned before a few of the variables that one would want to collect. Importantly for the EUP, we would want to observe and record any particular use errors. Now, note that in a lot of formative testing, or in a lot of typical sort of iterative testing during design, we use a talk-aloud protocol. In a summative test, talk-aloud protocol is not used because what we're trying to get at is as pure a measure of user performance as we can get to. So if there's any need or any desire to get more qualitative information, it is possible to get that, but only at the end when it is not, in fact, polluting or in any way getting in the way of collecting the data, the performance data. Lastly, we talk about reporting. Participants' performance on each task is recorded, and we want to get at those three things that we talked about in the very beginning with the definition. Some measures of effectiveness, efficiency, and satisfaction, where we might take, for instance, we recommend in the EUP that we take measures of the system usability scale or the SUS, and we really want to get some indicators of risk by looking at where people made mistakes and then what kind of mistakes they made. The common industry format is the recommended framework for reporting the results of validation testing. It is an approved, there is an approved ISO common industry format, or CIF. We have adapted that in NIST IR 7742 to work for as a template for recording results for summative or validation testing. Lastly, there's two essential elements. We want to prioritize the issues that impact patient safety and show a plan for mitigation of those risks. The focus overall is on identifying the root cause of those failures, and the data hopefully should be able to inform what needs to be addressed in modifying the user interface. So that's a very quick run-through of the information. So I guess I turn it to Pam here.
I have some questions. Will validation testing be required through the AARA?
Will validation testing be required through AAR, or ARR, ERA 2. I can't even say that, I'm sorry. You know what, that's a policy question, and A, I can't speak for anybody other than myself, and B, I don't think that, you know, that's not what the intention of the document is. It is purely technical guidance. So there's, you know, there's really nothing that I can say about that.
What's the difference between testing in a lab versus testing in the field?
I think there's a lot of issues with whether we want to test in the lab or test in a clinical environment. One of the things that we want to understand whenever we do testing is that we want to control as many things as we possibly can. And while yes, it is important that we understand how users will use the interfaces in the intended context of use, and that is obviously either in a busy clinic or in a doctor's office or in a hospital, we believe that we lose a lot of control if we try to put people in the floor of one of those environments and try to test. And so consequently, any errors that we would turn up in the lab would only be magnified in the field. So it's a different level of trying to understand the errors and the issues if we're trying to do those in the field. I think it's much better, at least in the early stages, in the first stage of doing summative testing. We try to do that in the lab where we can control a lot more of the variables.
As a follow-up, what do you think about simulating noise and distraction level in the lab?
It is a possibility, and I wouldn't rule that out. I don't think, as long as it can be controlled for everybody who's going to be using the test or using the application, I think that is a viable solution. But if it's going to have a differential effect, I would probably opt against it. So, you could simulate at least some noise levels. What we do know about noise and behavior is it does have negative impacts.
Do you recommend doing expert reviews on the same tasks, scenarios as the validation tests, and should they be conducted before the validation tests?
Yeah, expert reviews should be done before the validation testing for sure, because then the results of the expert review can be fed back into the design where there are changes that can be made. It is a much cheaper step to do that than it is to go to do a summative test and then make changes. So the expert review should be quicker, faster, and easier. Now, with respect to doing the same tasks, it's a different activity. I mean, one has to bear in mind the scenarios that are laid out in the EUP and take those seriously when you do the expert review. But they're not the same things as laying out a few of the tasks that specifically that you will have people do when you do the validation testing. Okay.
Okay, so if there aren't any more questions, if you do come up with more questions, feel free. Bob's email is up on the screen right now. The recording of this presentation will be available on SlideShare and Vimeo with links from our website, usercentric.com, most likely by the end of the day, but it may be another day. But we'll tweet when it's live. So thank you all again for attending.